available on call. I've dropped a message to sir.
Sure. I think we'll start on time, right?
We are live, please.
Good evening, everybody. I welcome you all to today's iFocus online session. We are currently running in the 439th episode, and this is a masterclass of 49th Cataract module. Today we have Dr. Arulmozhi sir, Director of UMA Eye Clinic, Chennai, to talk on the techniques of direct chop. Welcome, sir. Moderator for today's session is Dr. Varun Malhotra, sir. Sir has finished his MBBS from BYL Nair Hospital, Bombay, and PG from JJ Medical College, Davangere, followed by fellowship in cornea and anterior segment from Shankara Netralaya, Chennai. Currently, sir is a senior consultant, clinical head, cornea, cataract, and refractive services at Center for Sight Eye Hospital, Banjara Hills, Hyderabad. Sir is a course director for Eye Opener CME series for PG ophthalmology students. He's a research invigilator on the project on tear film analysis at Department of Clinical Sciences, University of Hyderabad. Sir has multiple publications and numerous presentations and awards in prestigious national and international journals and conferences. Sir has conducted various training programs in INTAX, Phacoemulsification, LASIK, lamellar keratoplasty, catalyst, and contact lens education. Welcome, Dr. Varun, sir. Over to you, Dr. Varun, sir, for the introduction of our chairperson, Professor Dr. Kamaljeet Singh, sir, and our speaker, Dr. Arulmozhi Varman, sir.
Thank you, Kritika. Thank you very much, and good evening for having me here. And I thank the organizers, and in particular, Dr. Santosh, for giving me this opportunity. I think Dr. Kamaljeet hasn't logged in till now, has he?
No, sir, I cannot see Kamaljeet, sir. I will. Yes, sir.
So I think you can go to the next slide. I think I'll just introduce Dr. Arulmozhi Varman.
Okay, sir.
So I would like to invite and thank Dr. Arulmozhi Varman for taking out time for this class. Dr. Varman did his basic medical education from Madras Medical College in 1980. He was a gold medalist, and also his ophthalmology education in the same college. He is the director of UMA Eye Clinic in Chennai and one of the leading ophthalmologists in Chennai. He has conducted over 150 phaco training programs and is a master in his craft. And I think it's a great opportunity for all of us to learn from him. I welcome sir for his talk.
Thank you. Can I go ahead and share my screen?
Yes, sir. Please go ahead, sir.
Okay. Fine. Let's we are. So good evening. So my talk is going to be on direct chop. So we can do a multiple varieties of handling the nucleus in phacoemulsification. We all know that there are several techniques. You have the 4-quadrant. That's the one that most of us start off with. There's absolutely nothing wrong with the 4-quadrant or the stop and chop. They're all excellent techniques. And direct chop has got something that scores over those two. Of course, we all know that 4-quadrant is kind of takes a long time. You need to keep doing 4 different trenches or at least 2 long trenches, intersection with a proper depth, proper width, and takes a lot of energy that's spent into the anterior chamber, which can be detrimental in a very hard cataract. 2, when you try to do these long trenches in a very hard cataract, the amount of force that we put on the nucleus itself can sometimes cause zonular issues. So all of these things are the negative points of 4-quadrant, though it's a very good technique to learn. It also needs a good dilation. It's very difficult to do in a small cataract, almost impossible. We come to stop and chop, which is a fantastic technique. A single long trench of the appropriate length and appropriate depth and appropriate width. And then you divide it into 2 halves, then start chopping up. What's the advantage of stop and chop? It's very, very predictable. You can actually make it similar in every single case as you get more and more experience. It will all look like the same surgery being done, though it's being done on different eyes. That's the advantage of stop and chop. And it's quite easy to teach also. So it's still, as of today, I would say that most people prefer to do stop and chop. Absolutely nothing wrong with it. What does a direct chop do? And what's the advantage again? A direct chop is much faster, much lower energy usage, more efficient, and it can be done whether you have good dilation of the pupil or not. Both the stop and chop and the 4-quadrant actually require a decent amount of dilation, at least 6.5 millimeters or more, to be easy to do. It becomes very difficult if you don't have that kind of dilation. In our country, with our pigmented iris, non-dilating pupil is far more common than good dilation. We all know that. So that's where direct chop comes in and becomes very, very useful. The direct chop also can be divided into two. You have the peripheral chop and the central chop. I don't like this terminology that some people use as a horizontal chop and a vertical chop. I prefer to use the terminologies peripheral chop and a central chop. I will show you what is the difference between these two and why you should kind of graduate onto one of these techniques. Preferably, I'll put my case forward to say, why should you graduate on and become the expert of a central chop? In a peripheral chop, as you will see in this video on the right side of your screen, you hold the nucleus, you take the chopper under the rexus, take it to the very extreme, to the equator of the nucleus, and split it from the equator in. Once again, you can see this being done. You rotate, bury, hold. The chopper goes under the rexus to the very periphery of the cataract, to the very equator, then chops it. So what is the advantage of the peripheral chop? Since you're going to the very periphery of the equator or to the periphery of the nucleus or the equator of the lens, the chop is very predictable. The chop would occur almost 10 times out of 10 predictably. But negative point is you have to carefully go under the rexus each time, very carefully. So that becomes easy when you have a fair amount of cortex and epinucleus, which acts as a cushion and gives you the space to manipulate your chopper under the rexus and take it right up to the periphery, the equator of the nucleus. Where you have a dense brown cataract with almost no cortex and zero epinucleus, getting under that becomes a manipulation by itself. You would have to orient the chopper horizontally, get under that, go back to the nucleus at the edge of the nucleus, then turn vertical, then try to chop. So there you can sometimes make a mistake and damage the capsulorhexis margin. Two, if you have a small pupil, or as the case proceeds, if the pupil becomes smaller, you are actually doing the procedure blindly. You're not sure that you've got under the rexus. So this technique becomes very dangerous or very difficult to use in small pupils. Again, most of our cases in our practice in India, a smaller pupil, 6 mm is the average dilation that you get in most cases. Very rarely do you get 7, 8 mm dilation, particularly in older individuals. Now let's look at a central chop. Here, I have already cleared the cortex and the epinucleus. You will find that the phaco tip enters into the middle and holds with vacuum, and the chopper stays right here. It doesn't travel down under the rexus, and there's no way that in this kind of a mid-dilated, fairly well dilated, but not really good dilation, one cannot see the edge of the nucleus. That's definitely, you can't get to the equator unless you're doing it blindly. While here, everything is done under vision. You hold, you bury, hold, lift up 0.5 millimeter with a lollipopping so that there is no stress on the zonules. Vertically take the chopper inwards, straight in, and crack and chop it right there. So the movement is very minimal, and then you separate. You get a very controlled, absolutely central, and one does not have to go under the rexus or under the iris to do this. Both these chops are very, very efficient, but the issue with the central chop, it is not predictable. Each chop will come out a little different. Each case will behave a little differently. So predictability is a little lower. That did not deter you from learning this technique. It's a very hard brown cataract, and we are able to chop it very efficiently in the center without going to the periphery. So I like to prefer to use the terminology of central chop and peripheral chop than using a vertical chop or horizontal chop, which I personally feel is wrong. So what do you do for a direct chop? Whether you're doing a peripheral chop or central chop, you should have one particular setting for chopping, which should be a low flow and a high vacuum. The second setting for the quadrant evacuation can be high flow, at a slightly lower vacuum, but if it's a hard cataract, we try to keep the vacuum also higher. Why do you want to keep the flow low during direct chop? You don't really want to aspirate anything. You really want to get hold of it. But when you keep low flow and high vacuum, the time taken for the vacuum to build up becomes too long. So with the newer machines, you can have a low flow, high vacuum, but you can set the rise time to be very low. You can keep the rise time to be 1 second or half a second, so that though it is a low flow, high vacuum, the vacuum, once occlusion occurs, is built up very rapidly. So you can still make the surgery very fast by keeping the flow rate a little low for your own safety. I like to keep a standard flow rate across all the procedures. So my flow rate is either 50 to 60 and a vacuum of 500 or 600. You have to understand what does flow rate do and what does vacuum do. Flow rate will pull pieces towards you once they are disassembled. Anything that is not disassembled is not going to be pulled out, even if the flow rate is high. Vacuum is going to hold. After vacuum is built up, it is going to hold very well. So the hold is very important when you want to do a chop. The hold also is very important when you have a very hard cataract and you want the energy usage to be lesser and you want vacuum to help the implosion of the piece into the phaco tip. So you still want to have high vacuum in hard cataracts and you want to have a high flow rate because you want things to occur a little faster. But I keep both the flow rate, vacuum, and also the energy at linear. So at my position 2, though my flow rate is set at 60, at the top of position 2, I'll be getting only 10. As I keep going down to become 20, 30, 40, 50, 60. And as occlusion occurs, vacuum was also on linear. So when vacuum occurs, if my at position 2, if my foot pedal is a little higher, I will not get 500, I'll get only 200. As my foot pedal, I push it down, I get higher vacuum. So actually with experience, though you have set standard flow rate and vacuum, you can manipulate these with foot control as to achieve lower rates of flow and lower vacuums as you would need at a particular case. As you will always do for when you're doing phacoemulsification and you set your energy at linear, you would be using enough energy, though you could set energy at 60 or 70 or 80%, you can use as low as 10% or 20%. As you see what is occurring, you increase the foot pedal pressure more, dident more, so that you get more energy. It's just like driving a car. You want to go faster, push the accelerator. You want to go slower, you come up on the accelerator. It's very simple. Nothing great here, just like driving a car. So by this, setting your energy settings, your flow rate and vacuum on linear, all of these can be set on linear in most machines now, except very entry-level machines. Most mid-level and of course all high-end machines, you can set all the 3 at linear levels, which gives you enormous amount of ability to tailor it on a second-to-second basis by your own foot. So high flow rate, as I told you, will build vacuum faster. One can set a low flow rate with a faster rise time to get similar results. High vacuum will hold very well. The higher the vacuum, better the hold, easier the chop. Higher the vacuum and harder cataract, it will implode the piece into the phaco tip with lesser energy, giving you more efficiency. Very important, whether you do any of these techniques, that you do not have any wound leak. A perfectly sized wound is critical. So if you're going to use a tip that is made for 2.2, please use the standard 2.2 keratome. If you use a tip for 2.2 and use the right sleeve for it, use the 2.2 mm sleeve. The tip and the sleeve should be the standard ones that are supplied by a standard company. Don't mix and match. When you have a 2.2 tip and then you have a 2.4 incision and you put a sleeve that is for 2.8, everything starts to go haywire. So don't do this mix and match. It's very critical that the tips and sleeves are from standard manufacturers or of standard sizes for that particular size of the incision that you've decided to use. Keep this in mind. That's the most important step of any of these surgeries. And even the side ports should be made appropriately with minimal leak. This itself will make your surgery much safer, irrespective of what kind of a machine you have. Again, I will emphasize, stick to standard phaco tips and coordinated sleeves. We buy a phaco machine for 10 lakhs, 15 lakhs, 20 lakhs, then try to scrimp and save because the tip is being sold by the company at 8,000, 10,000, 12,000 rupees. Somebody gives you a tip for 2,000 rupees. You want to pick it up. Sleeves that are much cheaper. Please don't do that. Please stick with standard tips and sleeves. It's very, very important. So central chop technique. How do we go about doing a central chop? First thing you do is clear, do a good rexus, important, agreed. That's extremely important. Appropriately size rexus. Now, clear the rexus area of the cortex and epinucleus and expose the nucleus. So here, most cataracts are 5 to 5.5 millimeters thick. Most of the cortex and epinucleus is about 1 millimeter to 1.5 millimeters. So the moment you have cleared the epinucleus and the cortex, you're already about 1 millimeter into the cataract. That means you have another 4 to 4.5 millimeters left in. So if you were to bury at the center and go down about 1 millimeter to 1.5 millimeters in, that means you're at almost 3 to 3.5 millimeter depth. That means you're at the half of the depth of the nucleus. That is when you will get a good chop. If you're very superficial and you're holding only the epinucleus and the cortex, you're not going to get a hold, you're not going to get a chop. So it's critical. This is cleared off in the area of the rexus. Second, when you clear off the area of the rexus of cortex and epinucleus, you know exactly where the rexus margin is, because as it proceeds and the view in the anterior chamber becomes murky, often one cannot see the rexus margin, and you can sometimes damage the rexus with your chopper. So this gives you an idea that your chopper has to stay well within the clearance area that you have created, where you have limited your clearance to the area which is delineated by the rexus margin. So please have a look at this video again. Clear, you've done the rexus, clear that area, very minimal. Most of the time, a soft cataract, it can be cleared without any phacoemulsification or any energy usage at all, with just flow and vacuum. In a harder cataract, you probably use minimal energy to clear it. So this gives you an idea as what exactly is the area, and your chopper will not leave this zone ever. Next, mentally divide the rexus area into 3. Upper 1/3, middle 1/3, lower 1/3. So you will now go and bury the phaco tip into the upper 1/3. Now remember, you're already 1 to 1.5 millimeters into the cataract. Your phaco tip is at least 1 millimeter diameter. So when that is buried in fully, it goes in at least 1 millimeter, 1.5 millimeters. That means you're already at 2.5 to 3 millimeters depth at the center. So that is very safe still, because the total thickness is at least 4.5 to most cataracts is 5 to 5.5 millimeters thick. So there is no fear that you're going to damage the posterior capsule. The chopper that I've designed, if you look here, it has got actually a flat surface. The cutting edge faces the phaco tip, and it's got a flat surface which is on both sides. So and it is sharp at the tip. The length is 1.75 millimeters. Again, there is no fear that the chopper will go and damage the posterior capsule. This is 1.75 millimeters long. You entered in 1.5 millimeters. Even if there's another 1.75 millimeters to enter into the nucleus, you're still at only about 3.5 to 4 millimeters. The cataract at this area, if you stay at the center, is at least 4.5 to 5 millimeters thick. So this chopper is not going to damage the posterior capsule. You don't have to worry about that. So once you go and bury the phaco tip, almost go down vertically, that you start at the upper 1/3 and do not cross the midline of the rexus area. Your burying should occur within the midline, so that the next half of the rexus area is used up for your manipulation of your chopper. As we go along, we'll see now. You go in vertically at the top, bury in, and you're still short of the middle. Take the chopper, enter in vertically, and separate. You get a beautiful chop, and a complete separation with minimal effort. You can repeat that again without even rotating, and you get the second chop without any effort at all. This is not a very hard cataract. It's kind of a grade 2. So again, look at this. Go and bury in the upper 1/3, critical. Do not cross the midline. This chopper enters past the midline, enters vertically into the substance of the nucleus, enters in, moves towards this, and then separates horizontally. And then because you have the flat surface, you get a good hole like a spoon, and you're able to separate it very easily. And even without rotating it much, you can get the second chop comfortably. So with no effort at all, one quadrant has already been separated. It can be easily aspirated this point itself. And you've got, so 25% of your cataract has already been removed. It's as simple as that. So again, separation of the zonules, the quadrants and the chop should always be done without any stress on the zonules. We'll go back to the previous chop. One other point I forgot to mention is when you bury and chop, you bury, and as you hold at that point, we tend to push down on the nucleus. One should avoid that. You should use appropriate energy to enter into the nucleus and not push. But even then, once you've entered and lollipopped it and holding it with vacuum, lift up the nucleus with the phaco tip by about 0.5 millimeter, not too much. It's just a small movement, so you're not stressing out the zonules, so that there is counter pressure for this chopper to enter in and then crack it efficiently. And it moves towards the center, and then you get a beautiful crack. Now let's go to the next. Separation of the quadrants. Let us look at that now. So as I told you, the second chop is done. It can be separated out. And you can try to take it out at this point itself. If the piece comes out, well and good. It doesn't rotate and go to the next piece. So once you have any difficulty, do not force anything. Go to the next piece, separate it so that everything is completely separated and they're independent of each other, so that the pieces come out very easily. Do not force anything at any point. Once you try twice, it doesn't work, don't waste time. There is something holding it. Rectify that. Don't try to take out a piece forcibly. Then you'll start stressing out the zonules and damaging the capsular integrity. So you'll notice here that hardly the cataract has been rotated so far. The first time I'm actually rotating it, that you're able to handle this very efficiently. The time taken is very less. You're not interested in just less time. The energy used up is also very less. The whole process is highly efficient, both on time, energy. The cornea is crystal clear. There's no wound distortion. There's no problems. You get better and better results. Look at it again. Bury second time, separated the same way. All of it occurs within the area of the rhexis. I try to pull this piece out. It has still not been well separated. I try it twice. Then don't. Just leave it alone. Rotate. Go to the next. It doesn't come. Don't force it. There's something holding it. So let's rectify it. Very minimal rotation now. Hold the piece. Again, this is in the center. The chopper goes in, chops, separates, all at one stroke, back again. Again, please look at this second chop. I want you to look at the second chop carefully. Hold. The chopper is always opposite to this. Don't keep the chopper here. It should be right opposite to the phaco tip. It's held. The chopper now goes down vertically inwards and then separates. So the hold is with the phaco tip. The chopper goes vertically inward. The left hand does more work than the right hand. Remember this. All the work of the chopper It should be more than what is done by the phaco tip. Don't try to do separation of the phaco tip. Most of the separation occurs with the chopper. So you'll find that this whole thing is so efficient, so fast. Again, I'll emphasize, we're not bothered about how fast you can do a surgery, whether you take 15 minutes or 8 minutes or 6 minutes. It is, at the end of the day, how much of manipulation that we do into the chamber, how much of fluid is flowing in and out, and how much energy you're expending into the eye. That's critical. It's not just the time. So advantage of central chop, it can be done in all grades of cataracts. I will show that to you, and also a soft cataract stone. It also can be done in small pupils very, very safely. That's a critical issue. So here we have a really hard cataract, rock hard, small pupil. So what have I done here? Is hardly a 3 millimeter pupil dilation. So what I do is, I'm not a very big fan of hooks or rings. I have nothing against them. They're fantastic devices. I end up using them pretty much rarely. I'm not that I don't use them at all. I do use rings. I do use hooks, but my usage is very minimal. So you'll find even a very hard cataract like this, you can stretch it to a rhexis that is a little larger than the pupil. So this is probably about a 5.5 millimeter dilation. The rhexis would end up at about just 6.5 millimeters under the, goes under the rhexis margin. Hydrodissection has been done. Now, since all the movements, all the manipulations are always done only within the pupillary area or within the rhexis area, you find no difficulty. I don't have to change anything. Only thing I have to keep in mind that I should not inadvertently go and chew up the iris. So you keep your flow rate low, keep your foot control very, very careful. Don't catch the iris. That's a catch. If you're not confident of not damaging the iris, strongly suggest that you keep hooks or you would have to use rings. If you're confident about your manipulations and staying absolutely in the center and judiciously using your foot, then you can do all of this even in a very, very small pupil as you're seeing now. You'll notice that both the instruments do not stray close to the iris or at any point go under the iris. Everything is in the center at the pupillary plane. As much as possible, I'm trying to do within the capsular bag, but wherever the pieces come out, I have to do it in the pupillary plane. I'm still using a high flow, high vacuum, but since it is on linear mode, I'm pretty much confident that I'm going to use my foot control to make sure that nothing goes wrong. This whole surgery was speeded up a little for convenience. So there we have, the pupil has not been stretched too much. So post-operatively, go back to normal size. The IA too. This is a very special IA tip that's been designed. It is absolutely brilliant. You don't have to go under the iris. It just grabs it and comes away without touching the iris. Again, I'll show this whole surgery again. Stretch the pupil. Again, you don't stretch it too much. You don't want the pupil to become very flaccid. You don't want the pupil to remain fully dilated post-operatively. Remember, if you watch carefully, you would find that there is literally no wound leak at all at the main wound or at the side port. This is critical. This is something that I want all of you to learn, that the wound sizing should be precise. It should be appropriate to the tip and the sleeve that you're using. That is why it's so critical that you use standard phaco tips and standard sleeves. Don't mix and match. Don't scrimp and try to save on those issues. They are very critical. Do not change them. So the tip, you will see that this is the tip that has been designed by me. It's under validation, and it's going to be soon available for sale. It has got a pentagon-like shape, and it has got a totally different architecture internally, where you would get excellent hold and very good followability with minimal chances of grabbing the iris. This is a very, very unique design, just like the unique design of the IA tip that you saw. So this is what also gives a certain amount of safety to the procedure. So by saying absolutely within the center, doing all the manipulations on CHOP in the central level itself, even a very small pupil and a very hard cataract can be managed very efficiently. Again, I want all of you to keep seeing that never do the two instruments ever stray anywhere near the iris or under the pupil at any time. The phaco tip stays absolutely central, stays in the bag. As the pieces come out, I have to do it in the pupillary plane, because I cannot stay under that. If the pieces start slipping out, if I stay under the iris, and I have the risk of pulling on the iris and damaging it. That's the worst thing that can happen. If you're doing this technique in a small pupil and then you damage the iris, don't hesitate, go back, immediately put in hooks. Again, I want you to observe that nowhere during this procedure is there any wound leak anywhere at the main port or in the side port. That is very critical. Please remember, it is not just the technique of your surgery, how you make the incisions, how you make the side ports, what kind of leak you end up in is also very important for having a safe and predictable surgery. Of course, other things that come into play are appropriate viscoelastics. I always use sodium hyaluronate with chondroitin. I use a double visco technique where we use the chondroitin under the endothelium and HPMC over the capsule. So that makes it easier, so that it's also gentle on the endothelium. And this kind of a cataract, it would also be prudent halfway through stopping and refilling. Again, watch, there's no wound leak, no flutter of the iris. So even if you have a floppy iris, if your wound is pristine, you can be sure that the floppy iris can be easily handled without having any difficulty. So keep these things in mind. So a lot of people would think that in a soft cataract, one cannot do a direct job. No, it can still be done. There's no issues with that. The only difference is that you would now go in, you would enter into the cataract using only flow rate and vacuum and not any phaco energy at all. Because if you were to use phaco energy, you would completely chew up the cataract, pull it out, and you will not get a hole, you will not get a chop. You need to get at least one chop clear in the beginning itself for you to get a safe procedure. So the technique that you can see now, the same, clear everything. That's the first step. That's critical. Always do that. No difference. The same chopper, I don't change anything. Here it's entered in with no phaco energy at all and separated. Once you get one separation, things are much easier. Actually, what happens in these soft cataracts, the difficulty comes in rotation. Because it is pretty sticky, it doesn't rotate. So here I just went ahead and got the cataract out, but I would suggest that go and re-hydrodissect once more so that the rotation comes easy. Particularly after you've done one chop, rotation becomes much easier. Then it doesn't matter in these soft cataracts if you can't get it into 4 quadrants, it will just fold and come over. There's no issues at all. So remember that. It just folds and comes over. So one does not need to do into quadrants. 2 hemi chops, that's one chop into 2 halves, and the whole soft cataract will fold over and come with no difficulty at all. So again, one can do a direct chop even in a very soft cataract. But one has to remember that you have to keep very low energy levels, which is easily achieved by keeping your energy parameters on linear. So even if you have set 60%, 70% or 50%, you're probably using 1, 2 or 3% for this whole cataract. Just emulsifies or it aspirates without the minimal amount of energy. So remember, a soft cataract gives you more trouble, not because of it's soft alone, it's because it's sticky and doesn't rotate. So doing a good hydrodissection, maybe multiple number of times, is more important. If there's any difficulty in rotation, stop, go back, do an hydrodissection again. Most of the time, the whole cataract will pop out of the capsular bag and it becomes very easy. Once again, go look at it. Clear the epinucleus and the cortex in the center. That's extremely important. That lets you know, again, by touching, just a touch, a nudge there will let you know how hard or how soft the nucleus is. So you know exactly how much energy that you have to use. Standard procedure, again, chop from there and separate. You get a fantastic separation. The rest of the thing is easy. As you'll notice here, the difficulty is in rotation. So if I really had to be prudent, I should have stopped here. I should have done hydrodissection again and done it, but it all depends on the experience you have and what you're more comfortable in doing. But I would strongly suggest at this point, stop, re-hydrodissect so that you will get a more predictable outcomes, or it makes your surgery more comfortable. You need not struggle like I'm doing at this point of time. Though I've got the job, this is something that these are extra manipulations that one can do without. Taking out the central core, taking out the central core. Now, once the rotation comes, everything starts to fall into place. It folds and comes over. So the central direct chop, as I would say, is an ideal for all cataracts. It gives you a large safety margin because you're staying within the capsular rhexis area. You hold inside in the middle, in the upper and the middle 1/3 of the nucleus, and you chop directly into it. The central chop is probably the most efficient, particularly in our country because we have more small pupils. We are more comfortable doing a direct central chop. Thank you.
So I think that's a great learning exercise for all the postgraduates. Thank you, sir. Thank you very much for sharing your expertise in Phaco and especially the direct chops with us. I would like Dr. Kamalji to make his comment.
Wonderfully explained all hard cataract, soft cataract by sir. It's a treat to watch him do the surgery. And one thing I would request to young colleagues, sir is a very, very experienced surgeon. And what young people can do is they make a larger capsule for doing the job. Because if the rhexis is small, then you might touch the capsule and your capsule will have a break in the entire capsule. And then your surgery will become difficult. The same is for softer cataract. Younger cataract, less than 40 years old patient. What I do is I make a slightly larger capsular rhexis, 6 millimeter maybe, and do hydrodissection, and I find that the nucleus pops out. And then I simply do phacoaspiration, no talking, nothing, and the surgery is over in 2 minutes. So that can be tried by young persons, and this is a difficult job to do in soft cataract. Sir has explained it very well, and I have also been benefited by his talk. Thank you so much.
Ritika, do we have any questions from the PGs for Dr. Varman?
Yes, sir. There is a question on YouTube platform, and the question is what type of chopper to use.
Yeah, that's if you're doing a peripheral chop, where you go under the rhexis and then you take the chopper to the equator and you chop, then you should have a chopper that has got a blunt tip. You can't use a sharp tip chopper for that peripheral chop. If you're going to follow my technique of central chop, it should be a sharp chopper. It has to be sharp, and this design is my own chopper design. where the sharp edge faces the phaco tip, and there's a flat surface on the both other sides, so it gives you a good leverage. So these choppers, anybody can make it. It's nothing, no high tech about it. So if one is very scared about using a long chopper, start with a 1.25 length, 1.25 millimeters. But I strongly suggest for hard cataracts, you should have a chopper that's at least 1.5, if not 1.75 millimeters long. So that gives you the leverage to break a soft cataract. I mean, sorry, a hard cataract. In a soft cataract, even a 1.25 millimeter chopper is good enough. So
Even a dialer would do, sir.
Sir?
Even a dialer would do the job.
Exactly. In a soft cataract, even a dialer would do. So, but what I feel is that, I don't want to learn multiple techniques to handle the cataract.
Very right.
I like to stick with one technique, one chopper,
right.
which will work for everything, but one has to learn this.
Yes.
There are guidelines, as you said, in a soft cataract. Actually, a soft cataract give you as much trouble as a black cataract, because it is sticky, it does not rotate, you have more issues. Of course, the easy ones are the moderate ones, the grade 2s, grade 1s, grade 2s are the easy ones. Exactly what you said, do either I chop and then do a hydrodissection to pop it out, or it pops out on its own. That's the beauty to do. Excellent. What I like to do in a soft cataract where it gives me trouble, I like to get one chop, one break. If it doesn't steep come out, do a very gentle hydrodissection using viscoelastic itself. That will push the whole thing out. There are multiple ways of doing it. One has to learn.
Yes.
Any other questions?
Kritika, any more questions for him?
Sir, I have a question, sir.
Yeah.
What is the technique of nucleus management we can use in a case of posterior polar cataract?
Posterior polar cataract is very simple. One has to do hydrodelineation.
Yes, sir.
Don't do
And about the
hydrodelineation. Do a mechanical separation of the capsule superiorly. Then you do a hydrodelineation, pop it out. Try not to rotate the whole cortex, because sometimes when you try to rotate, the whole cortex rotates, then the posterior opening opens up. So the rotation should be very careful at the nuclear level. Then, like folding over, a flower petal, one has to pull on the cortex and epinucleus, fold it over, bring it to the center, not yank it out, and finally get it out. And keep certain viscoelastics ready, like Helon GB or more viscous viscoelastic, so that if the posterior capsule dehiscence occurs, you plug it. So that should be kept ready on the table or just ready to be opened. You can't be searching for it after something goes wrong. So keep these things ready. That's where we go wrong. We get into a problem, then you ask for Helon GB, and then they go running around looking for it, searching for it, and everything goes out. So either you open it out and keep it on the table, spend the money, or keep it ready right there under your vision, that when you ask, it is ready there for you. And of course, we know that in a posterior polar, never come out without putting in viscoelastic. So always keep the chamber formed. So with these things, you can get away with quite a bit of issues in the posterior polar cataracts.
Sir, you can do a pre-operative anterior segment evaluation also.
Yes.
About whether it's posterior subcapsular or posterior polar, or whether the pre-existing opening is there or not. If you do it beforehand, then you will be, it's hardly in 10% that you get a pre-existing opening. So you'll be comfortable and you'll be able to do the surgery.
You'll be more prepared. You'll be more prepared, having the right tools, and you keep your vitrectomy also ready. You'll have the proper viscoelastic. When you know the anterior segment OCT tells you there's a dehiscence in the posterior capsule, then you would keep all of those ready so that you will not be found wanting when something starts to go south.
I think, Kritika, there's another question. Please, can you just ask Dr. Varman?
Yes, sir. There is another question by Dr. Ishita. And the question is, what should a beginner surgeon do in case of a hard cataract and pseudoexfoliation with small pupil?
Exactly. The technique that I showed can be done even by a beginner, as long as you're following all the steps that I have told you to. Stretch the pupil, put in good quality viscoelastics, stay in the center. But until you really get very conversant and an expert at this thing, put in hooks or put in a ring expander, whichever you're comfortable with. Then you slowly graduate onto these things. Getting in a hook or putting in a ring is not very difficult at all. So one has to learn that also. Not that you shouldn't, but as you gain experience, you can do difficult cataracts without hooks or rings. That is possible. But for a beginner surgeon, I would say strongly, as a beginner surgeon, start putting hooks. As you become more experienced, go to rings. As you get more experience, you can discard both.
A young surgeon can do SICS also.
Yes, sir. Sir, I personally feel that SICS needs more skill than phacoemulsification. That's my personal view.
He's
That
asking
was
this
some
question.
Not that it's. I don't think it's just that they experts make it look easy. It's not that easy. It's not.
No, it's not that. Yes, sir.
Sir, I wanted to ask you one question. What would, in your view, be an absolute contraindication for a direct chop in a phaco?
Nil. Nil. I do a direct chop even when there is zonular weakness. Then in that case, I put in capsular hooks and I still proceed. So if you, my contention is very simple. I do the rexes. If the rexes can be done safely, then you can do phacoemulsification and get away with it. Of course, you may have to put in rings, you may have to put hooks. But if you cannot do the rexes at all, that the zonule is so weak, then everything is completely off the table. Then you have to go out thinking what you will do. Probably you will end up doing DCCE or something like that. But my contention is very simple. If you can do a rexes, you can do a phacoemulsification.
Right. Kritika, any questions do we have?
Yes, sir. There is one more question by Dr. Ishita again.
Yeah, she
And
said
the question.
about, yes, doing sphincterotomy. Yes, I'm sorry. Yeah.
Sorry.
I saw the question. Sphincterotomy in case if there is an iris prolapse. Okay, simple. I'm going to explain that right away. Sphincterotomies are excellent. They're nothing wrong. They actually sometimes are more aesthetically pleasing than simply stretching the pupil. Yes, if you're going to get iris prolapse, it's going to occur only if your incision is too large. If it's a precisely sized incision, you're not going to get iris prolapse. Okay, then as you come out, you could get an iris prolapse if there is posterior pressure or the patient is strained. So that's different. Getting an iris prolapse when the phaco tip is inside is a mistake of the surgeon, in my opinion. That means your incision and your tip and sleeve did not match each other. If that is matching, you will not get an iris prolapse during your procedure. Yes, anybody can get an iris prolapse as you come out. If the patient is straining, the posterior pressure, if there is misdirected aqueous into the posterior, into the vitreous, there are so many reasons that can occur. Agreed, all of those are different. So please, most of your problems are solved if your incision is precisely sized to the tip and sleeve you're using. That is why do not mix and match tips and sleeves. Do not try to save money on tips and sleeves. Stick with very standard ones. So sphincterotomies are great. There's no issues. If you're going to get repeated iris prolapse every time you come out, you may be better off doing an iris tap, doing a small vitrectomy, a vitreous tap, or doing a small vitrectomy to reduce the posterior pressure that's coming up. Or maybe you take off the pressure of the speculum, or make sure the patient is not straining. You could even give IV mannitol and see on the table. All of this can be tried. Again, once this occurs and you think the iris is going to give you trouble, please put hooks immediately. Don't wait until things go overboard and you've gone over the hill and then you're down the slope. Then the iris starts to get chewed up, then you start having iris missing. Don't do that. At the very first sign of difficulty, take appropriate steps to overcome the difficulty.
Sir, two things can more be done. One is that you apply a stitch if you are a younger surgeon. If you find that iris is coming out, simply put a stitch at the main wound. And then you make another incision, phaco incision. And through that, you can do the surgery. But secondly, what you can do is, you can do a small peripheral iridectomy. You will find that your iris will not protrude out.
Won't come out.
So
Agree.
these two things one may try if it is feasible. And
Yes.
sphincterotomy, one should, from the very beginning, one should think of doing. If it is 5 millimeter or less, then you should do sphincterotomy. And even 3 cuts at the sphincters are more than enough. Don't go up to the periphery. Just give on the sphincter, just a small cut at 6 o'clock, 9 o'clock, 3 o'clock, you will be able to perform the surgery very well. So this can be tried.
Yes, sir. Perfectly right.
Thank you.
There is another question on YouTube, sir, by Dr. Naveen Jain.
Yeah.
And the question is, during quadrant removal, how to manage the machine surge? I think he's asking how to prevent the surge during quadrant removal.
Yes. Surge is something that's really come down significantly, even in the so-called low-end machines, because our tubings have got better, our pumps have got better, software has got better. So the surge should not occur. You will have to know the behavior of the machine that you're using and appropriately set the flow rate and the vacuum. That is where your understanding of the machine is very important. Certain machines you can go up to flow rate of 50, 60 and a vacuum of 600. In certain machines, you will not be able to do that. You may have to stay down at 30 or 40. So one has to understand the behavior of the machine that one is using and then appropriately set the setting. That's what I would say is the way to go about it. In spite of the best of all these things, if you do, if there is inordinate leak in either your main incision or the side ports, however good your machine is, you're going to get surge. So please remember again, I'll go back emphasizing, if your wounds leak, you're going to get surge. In spite of that, if you're going to get surge, then the other reasons are posterior pressure, patient's training. Those are the other issues that we look at.
Sir has already mentioned that the incision should be proper.
Yes.
But if the incision is not proper and you find that the fluid going in is less than the fluid coming out, then you will definitely get surge, whatever machine you have.
Yes,
So
sir.
make an incision, which is, as sir has already in his beginning remarks, has said that the incision should be perfect. That will help you a lot in keeping the NTA chamber watertight.
Most of the time, sir, the people don't make a bad incision. They choose the wrong tip and sleeve because
Yes, sir.
they pick up what is available and
जो assistant दे देता है उसी से डाल देता है.
whatever is there. That should never be there. Your OT cannot have inappropriate tips and sleeves. It cannot be there because you're not the one putting on the tip and sleeve. Your sister is doing it and she can't be blamed giving you a wrong one. If you have given
Today I was doing surgery, sir, and he had 2 choppers only. I was asking for dialer. I used to say, "Yaar, tum naraz ho kya humse? Bar chopper de rahe." Then he saw that both were choppers.
That's another issue.
So that kind of mistake can occur with the assistant. That you have to take care of. Finally, the
Kritika,
yes, it's
Dr.
now your
Kritika,
turn.
have we done with all questions or do we have any more questions for Dr. Varman?
No, sir, I don't find any more questions on both the platforms.
Right. I think there's one more now.
Yes.
Okay, that's good. That's a good question. What if there's a small pupil and patient wants to go for femtosurgery only despite proper counseling? These days, this is the most difficult. I even faced it this morning. It's a very, very difficult situation to be in. And these are people who insist on femtocataract surgery. If you're adventurous, you don't mind taking a small amount of risk and the patient is so, you can stretch the pupil, put in a viscoelastic and do visco stretching and take the patient. I do both in the same theater. I have a microscope there. And then you'll have to increase the power setting of your femto machine so that it will penetrate through the viscoelastic and do it. But it's a kind of a mess. I would rather tell the patient, no, it's not worthwhile doing it for you and then proceed. But unfortunately, there are some people who are fixated on this and they come and eat our heads telling, I want only femtocataract surgery with a pupil that only dilates to 4 millimeters. So that's a very difficult situation. And
No, sir, you see, sir, the surgeon should mention what type of surgery he is going to plan. The counselor always try to give you lots of money. So they always prefer that femto can be done in all the cases. So if the surgeon has mentioned that I will do just the phaco, normal phaco, or SICS or whatever, then it should be mentioned by the surgeon, and that surgery only should be planned. Otherwise, it becomes a difficult problem. I did a toric lens in a 55 years old male, and the next day they brought a 85 years old man having a grade 5 cataract for toric eye. And I don't, we don't have femto etc. and all that. So I said, यार इसमें normal cataract करवा दे भाई, काहे को इतना महंगा लेंस लगवा रहा है? तो थोड़ा स्टिग्मेटिज्म हो जाएगा 85 साल में, तो क्या परेशानी? So the surgeon has to mention this, that this patient needs this surgery. Otherwise, they don't know. The counselors don't understand the intricacies of surgery. This is my humble request to
that's, most often this kind of thing I see in my practice is where this person is read about it and wants only femto, not because we told them femto. So they are fixated. I can afford femto, I want only femto. That's a kind of attitude.
हमारा मरीज तो खड़ा हो जाता है, हाथ जोड़ के कहता है जो आपको करना हो करने कर लीजिए सर, हमारे पास इतना करता है.
So that's this actually happened to me, not today, yesterday. I've done the surgery and reviewed the patient today. She's fine, she's happy, but then we had a lot of difficulty counseling, and they had gone to 2 places, been turned down, and they came to me and said, I want only femto.
And this happened with Shah Rukh Khan also. People refused the surgery, and it was done. Because of his insistence, the surgeon did the surgery, and his hands were burned. So the surgeon has to take all the responsibility and decide. Thank you, sir. Thank you so much. It has been a wonderful meeting. I learned a lot from you.
One second.
Well, I completely
Somebody's asked one question.
Dr.
Can we dilate the pupil with iris retractors and take patient? No, you can't do that, because once you put the iris retractors in place, then you can't do the suction cone on the eye. There should be nothing. You can stretch the pupil, it will come back to normal unless you're going to have viscoelastic in the anterior chamber. That means you have to put viscoelastic to keep it dilated, and then you'll have to increase the power energy settings of the machine and then do that. I've done it. It's a mess. It's a mess. It's not something that you would like to do. Retractors can't be kept in place. Not possible. Whether you can put a ring, for example, I really think that we can keep Bhattacharya ring in place and keep just saline or BSS in the anterior chamber, because it goes through 1 millimeter incision. Then you can, I have not tried it yet, but I think that will really work. It's one of the things that I guess will really work, because that keeps the pupil at around 6.5. You can do a 5.5 millimeter rexis and go ahead. Where you need not do anything, it's a 1 millimeter incision, put it in, then evacuate the viscoelastic, put only BSS, then you're back to square number 1. Hydrate the wound, then you can go ahead. Yeah, that's fine. I've not tried it yet, but I suppose that's possible.
So I think that's been a great lecture by Dr. Varman. I think all of us have learned a lot, and of course, experienced surgeons will also benefit from this, from his experiences. And I would like to thank Dr. Varman for taking out time in the evening for us, and Dr. Kamaljeet Singh. And over to you, Kritika.
Thank you. Thank you so much. Thank you all.
Thank you all. Thank you.
Though I was having fever, I enjoyed a lot.